medical student. One more time. Assalamu alaikum, everyone. My name is Shahad Hammad. I am a fourth-year medical student, and today I'll be giving you the lecture of integrated control of the cardiovascular system, both 1 and 2 lectures. How this is going to work, I'm going to divide the lecture into 3 parts. The first lecture will entail the first 2 objectives, and the second lecture will have the third objective. If you guys have any questions at any point, you can stop me at any time, either type in the chat or unmute your mic. I will also be asking a few questions here and there, so try to stay interactive throughout the session. Otherwise, we can begin. Bismillah. So with the first portion of this lecture, I want to talk about skeletal muscle circulation. So as you guys know, we have different types of muscles in the body. Skeletal muscle, which is including the muscles of the arms and the legs and, different types of muscles in the body. We also have the cardiac muscle, which includes the heart, and we have smooth muscle, which is found in the GI tract, like the stomach or the intestines. What we'll be talking about here is specifically skeletal muscle and cardiac muscle. So first thing that I want you guys to know is the rate of blood flow in skeletal muscles. I want you guys to memorize these 2 numbers over here. So at rest, the rate of blood flow, which is the amount of blood flowing in the muscles at a given time, is 3 to 4 milliliters per minute per 100 grams of muscle. You don't need to remember this long metric unit thing. Just remember the number for now. So at rest, say right now you're listening to the lecture or you're sitting down, you're relaxing, your rate of blood flow in the skeletal muscles will be 3 to 4. However, when you are exercising, what happens in the body is that there's a higher demand for oxygen and a higher demand for blood. And because of this 3 to 4 milliliters is not going to be enough. So what does the body do? It will try to compensate for this by increasing the rate of blood flow. So when you start exercising, your blood flow will increase to up to 200 milliliters per minute per 100 grams of muscle. Now we can see this here on this graph on the right. I want you guys to focus on the x-axis and the y-axis. So we have the minutes and we have the blood flow. From 0 to 10, let's say this is you relaxing, studying your lecture, sitting, not really relaxing when you're studying, but when you're, calm, you're not moving your body, you're not utilizing your muscles enough. This is when your blood flow will be at 3 to 4 milliliters. However, once you start exercising, which is beyond this 10-minute mark, we have a rapid increase in the rate of the blood flow. You can see it's a very steep line over here. And this is when we see the drastic difference in the number from rest to exercise. And then once again, after the exercise ends, the blood flow will decrease once again. So this is one mechanism by which the body will compensate for the increased demand in oxygen. One more time, memorize these numbers. At rest, you have 3 to 4, and with exercise, it is up to 200, which is a 25 to 50-fold increase. Now, another thing is that if you're increasing the blood flow, your body has to compensate somehow. You can't just have the blood flowing in the limited number of capillaries. So what happens is that these capillaries will increase in density. So say that we have a muscle fiber over here, this one here, and it has these 4 capillaries. What you can't see here is that there are a few capillaries which are actually closed and there's no blood flowing through them. This isn't pathological. This just means that you're going to have an increase in blood flow. And how this happens is that we're going to have these closed capillaries opening. So you can see from normal to exercise, we have a lot more capillaries within the muscle fiber. And this will allow the body to compensate for the increased blood flow so that more blood can flow through these capillaries. So again, one more time, we have an increased rate in the blood flow from 3 to 4 to 200, and we have an increase in capillary density. These are 2 mechanisms. The next thing that we want to mention is vascular and nerve stimulation. Vascular means the blood vessels and nerves means nerves, self-explanatory. So again, we have this increase in blood flow, increase in the rate, and we have increased capillary density. Is this enough? No. What we want to do further is increase the diameter of the blood vessels. Because imagine you have these blood vessels and they're working normally, and suddenly there's a large rush of blood coming through them. What's going to happen is these are very delicate structures. Capillaries are 1 cell thick. So what's going to happen is that if there's an increase in blood flow and they remain as small as they are, there's going to be some sort of rupture. So how does the body compensate for this normally? We have something called vasodilation. And vasodilation, if you just break it up into 2 words, vaso means vessel and dilation means increase in the diameter. And what happens here is that during exercise, again, we said that the muscles need more oxygen. because of this oxygen, the muscles will be able to work. So the muscles will use up this oxygen and they'll be needing more oxygen to come to them. So they kind of send out a signal, and this signal is in the form of vasodilators. Vasodilators are chemicals or certain substances released by the muscles to induce vasodilation. And these ones you have to know them very well. Adenosine, potassium, ATP, lactic acid, and CO2. Know that these are 5 of the normal physiological vasodilators. Okay, so these are 3 changes. I'm just going to keep repeating things so that it sticks with you guys. We have the increase in the rate of the blood flow, we have increased capillary density, and we have our vascular changes. The 4th one is nerve stimulation. All of these different mechanisms work together to be able to compensate for the increased demand. So what happens with nerve stimulation? We have the same thing. The muscles will use up the oxygen. There will be a reduction in the oxygen stores, and we'll have the release of something called catecholamines, which are norepinephrine and epinephrine. I'm not sure if you guys studied this in a different lecture, but these will work on the sympathetic stimulation. And we have things called sympathetic and parasympathetic stimulation. I'm sure you guys had a lecture on this, so it's not the main focus, but I'll just go over it. Sympathetic is our fight or flight response. And what the body does here is that it's going to prepare the body to fight or flight from a situation. So it needs to get the body prepared, get it tense, get it ready to be able to, act accordingly. So what happens, we'll have increased cardiac contractility, we'll have increased blood flow, we're going to have vasoconstriction in areas where we don't need those organs, and we're going to have a bunch of different changes. So what happens here is that we have our norepinephrine, which causes vasoconstriction, and we have our epinephrine, which causes vasodilation. And you might be wondering, why are we having 2 contradicting actions due to the nerve stimulation? Now, what happens here is that when we have our sympathetic stimulation, we're having all these changes to increase the cardiac contractility and increase the effectiveness of the body. And this includes both vasoconstriction in areas of the body where we don't need those organs. For example, we don't need the GI tract. We don't need to be digesting in the middle of fighting something. But we need vasodilation in places like the muscles and like the heart so that the body can act accordingly. So these 2 things will act simultaneously in the body. However, in cases of exercise, we need to have vasodilation in majority of the places. And because of the other mechanisms that we mentioned, which is the capillary density and the vascular changes, the vasodilation effect is much greater than the vasoconstriction effect. So because of this, we have 2 different changes. Someone asked a question, another lecture we took, that ATP compounds are vasodilators. So how is ATP a vasodilator? Okay, this question is because the ATP will have an end product, which is ADP. This one, I just took it directly from your lecture. This is how your doctor described it, but if you want to put it in a way to understand, we know the ATP pathway starts with ATP into ADP to AMP into adenosine. And the end product of ATP being used up ends up with a vasodilator, which is adenosine. So if you want to think about it that way, that's how we can think that ATP is a vasodilator, but I get your confusion. Unfortunately, this is the way the doctor wrote it in his slides, and I'm worried that he kind of tries to move around it that way. So just for now, remember that adenosine itself, or the ADP compounds, as you said, are the vasodilators. I hope that makes sense. Okay, so the next part. We said vascular changes in nerve stimulation. This is kind of a summary of what I just said. The sympathetic system or stimulation is the fight or flight response. We have, again, the increased cardiac contractility, which increases cardiac output so that more blood and oxygen gets throughout the body. We have vasoconstriction in certain areas. Vasoconstriction causes the blood vessel to, get more narrow. And because of this, the blood that's moving through it will push through these constricted walls, and this will increase the pressure pushing on the walls. This happens throughout the body, as I said, either in places we don't need the stimulation or the organ, and in places where we want the blood to be pushed back to the heart instead of staying in these veins. Now, what we want to distinguish from this point, or the most important point of this slide, is that the vasoconstriction can happen wherever it needs to happen in the body, except the heart and the brain. And this makes sense because if we had vasoconstriction every time we got nervous or every time, we had to exercise, then it would cause a lot of problems to the brain and to the heart if it was constantly being vasoconstricted and cut off from blood supply. So again, just remember that vasoconstriction can happen throughout the body depending on the stimulation, except the heart and the brain in different conditions. Another thing like I said, is that we have increased constriction in the large veins because we want the blood to move back to the heart so that we can have, more blood flow through the heart and again throughout the body getting oxygenated and all of that. So the sympathetic stimulation is more for a different physio lecture or something else you took, but this is just to put it in the perspective of exercise and cardiac stimulation. Okay, this is just a schematic diagram showing what I just explained. So if we have someone exercising their legs, if they're running or having a leg day at the gym, we're going to have blood flowing from the heart over here, going to the legs. And we have a lot of blood flowing in these areas. However, for the parts of the body that we don't need, we're having vasoconstriction so that the blood does not get redirected to these areas and can go straight to the legs. So for example, we have the kidneys, not much use for them, the skin, the non-exercise muscles. And this all redirects majority of the blood to the legs. And like I said, it has little effect on the brain and the heart. As you can see, the degree of constriction in these areas is kind of, a little smaller than the other areas here. So this is just showing the same thing that I just explained. One more time, we have increased heart contractility, vasoconstriction in areas where we don't need the blood flow, but vasodilation in the places we do need the blood flow. And this vasodilation is due to either vasodilators or increased capillary density. And with that, if you guys have any questions, you can stop me and I'll answer them. Otherwise, I'll go to two different examples and then we'll finish up with the first part. So two examples here where I want to put these things into perspective is these two gentlemen doing different things. So for the mean arterial pressure, or MAP, we have this formula here, which is flow is equal to the difference in pressure over resistance. So the flow will be directly proportional to the difference in pressure, meaning if the pressure is increasing, then the difference in pressure is increasing, then we have increased flow, and the opposite in the other way. And we have an inverse relation to resistance. So if the resistance is increasing, that means it's stopping the blood flow more effectively, and that means the flow will decrease. Now, if you put this in the perspective of these two pictures, on the left-hand side, we have these two guys over here, which are, building something on the roof, and they're only really utilizing their arms and their hands. So what do you guys think are gonna happen to the vessels in the arms and the hands? Vasodilation, dilate, perfect, exactly. So in the arms and the hands, we're going to have vasodilation. Meanwhile, in the rest of the body, what are we going to have? Vasoconstriction, exactly. So because of this difference, the arms and the hands are a very small portion of the body as compared to the rest of the body. So that means there's more vasoconstriction in the body than there is vasodilation. And that's why the mean arterial pressure is so high in these guys. It's 170 millimeters mercury. However, this person over here, what do you think is going to be the majority effect in his entire body? Is it going to be more vasoconstriction or more vasodilation? Yes, vasodilation, because we have him utilizing his entire body, meaning all the muscles. I think swimming requires every single muscle in your body. You have to use your arms, you have to use your abdomen, the legs, everything. So all these places will need more blood in them, and hence there's going to be an overall vasodilatory effect, and hence the pressure in these veins will be less. So over here we have 20 to 40. The kind of summary of this point is that if we have less total vasodilation, we have higher resistance and higher MAP, which is the case in these guys over here. They have more vasoconstriction throughout the body, which increases the resistance, and we have a higher mean arterial pressure. You guys know what mean arterial pressure is, right? The mean arterial pressure, meaning the pressure of blood in the arteries throughout the body. Yes. So it's pressure, higher pressure because the place is getting, I think you made a typo, but essentially I kind of understand what you mean. It's higher pressure throughout the body because more places are getting vasoconstriction. Like we said, the arms and the hands are getting vasodilation because they're working. I mean, because 170 is higher because less places are dilated. Yes, exactly. Less places are dilated throughout the body, so the pressure is higher. You are correct. So let's move on to the next part. If you guys have any questions, feel free to stop me at any time. Now, we're going to go into more graphs in this lecture. There's a lot of graphs, but they're all very simple. So before we go into the schematics or the changes in this graph, I just want to break down what exactly this graph is telling us. So in the right atrial pressure, on the x-axis over here, we can see as you move more towards the right atrial pressure will increase. Meanwhile, on the y-axis over here, we have cardiac output and venous return. When we're looking at these two, we're looking at two different lines, okay? This black line over here is at rest. This red line over here is exercise. This line moving upwards is the cardiac output, and this line moving downwards is the venous return. Okay, keep this in mind, orient yourself while we go through the graph. This point over here, point A, is where the patient or the person will be at rest. The point of intersection of cardiac output and venous return. They always have to be equal. And in this case, it's 5 liters per minute, okay? And this 5 liters per minute is found at a right atrial pressure of 0. So in an ideal patient or an ideal person, they won't be a patient if they're at the ideal state. In an ideal person, the cardiac output and the venous return will be equal to each other at a 5 liter per minute rate. And the right atrial pressure will be 0. Why is it 0? It's because the right atrium is not pooling up with blood. It is not failing to do its job. So the blood is moving smoothly throughout the heart, and the blood is not being backed up in the right atrium. So that's why the pressure in the atrium is 0, and it's fine. Everything is good in this case. Okay? What happens during exercise? What we have here is an upward shift in the cardiac output, this line over here. Why do we have this? It's because, as we said, during exercise, the body needs more oxygen, needs more blood to be spread out. So we need to have more blood leaving the heart to these places. So the cardiac output at point B will increase from 5 all the way up to here. Let's say this is 21, okay? Another thing is that the venous return will also increase from its set point down here up to here. The venous return is increasing because there's more blood coming back into the heart. So basically, essentially, when we have this change in rest to exercise, the heart can easily change from its resting cardiac output and its resting venous pressure and efficiently change to a higher rate without changing the right atrial pressure. And this is a key point that you will need to know when we get to the pathologies or the diseases. Because as you will notice, in an ineffective heart or in a heart that we will see in the future slides, we'll see a change in these graphs, but we'll also see a change in the right atrial pressure. As you can see here, let me get rid of a bunch of this. As you can see here, the right atrial pressure remains at a low number even during exercise, okay? It doesn't go too high. It changes from 0 to about +3. And this is good. This is what we want. We don't want the right atrial pressure to go higher than, let's say, 5 or 6, okay? This is indicative of a disease. So again, in a normal person, we have the normal cardiac output and venous return at 5 at 0 atrial pressure. When we exercise, the cardiac output will increase, the venous return will increase, but the atrial pressure will not increase or increase minimally, okay? Does this make sense before we move on? Because a lot of the rest of the lecture will hinge on this understanding. Yes, okay, perfect. So what we're going to look at here is that the mean system, if we just look at this in words, we have the mean systemic philic pressure increases during exercise. Like we said here, the blood coming from the systemic circulation will increase during exercise up here. There's decreased resistance in the blood vessels and active tissue, and we have changes in the cardiac reserve. And this is a very important point that I will point out. Let me just read the chat. Venous return and cardiac output are the same line. No, they're not. As I said over here, this one here is the cardiac output. This line that's curving over here. This line going downwards is the venous return, okay? A way to remember this is that as the right atrial pressure is increasing, the venous return will decrease. And why is this? Because if the right atrium is, getting filled up with blood, the venous return is supposed to come into the right atrium. But if it's already full, then it can't come back. It's going to get backed up in the systemic circulation. So as the right atrial pressure increases, the venous return decreases because the blood is getting backed up in the rest of the system. okay? So this downward curving slope is the venous return. The upward curve is the cardiac output. Okay, the letter to the plateau is the reserve. Yes, the reserve, I'll get to that in a second. What is the meaning of, what is mean systemic filling pressure? Mean systemic filling pressure is the total amount of blood returning to the heart from the systemic circulation. So after the blood passes through the entire body, when it comes to the inferior and superior vena cava, that blood that's coming back is the mean systemic filling pressure, okay? It's the pressure in those two vessels. They both increase together, right? Yes, they do increase together. Okay? Is this all clear to everyone? If you have any more questions, ask me now, because understanding this will, depend on everything else. All clear? Okay. So someone asked about the, the cardiac reserve. That's the point I was going to get to. So this part down here, the change in the cardiac reserve. When we have exercise, we can see that there's a change in the pressure from here to here, okay? This space over here is our cardiac reserve. This is the maximum percentage that the cardiac output can increase above normal. What does that mean? This is the amount that the cardiac output can compensate when we have exercise, or this increase from point A to point B, from 5 to 21, we said here, okay? This is very important because in certain diseases, we're going to have a decrease in the cardiac reserve because the heart is not able to compensate for the increased demand in the body. So just to summarize all of these points that we said before, this change in these graphs increasing together is because, one, of sympathetic discharge, we said the fight or flight response, decreased parasympathetic, which is the relaxing response, kind of the opposite of sympathetic, increase in heart rate, increase in mean arterial pressure, and increased heart strength. This is another example of the cardiac reserve. If we have our cardiac, let's say our volume over here, and we have different types of diseases, okay? In a normal person, their cardiac output is 400%, which means that, this part over here is pretty normal. This is the average number of, or the average percentage that the cardiac output can increase, okay, 400%. In an athlete who is actively training their heart all the time, they'll have a greater cardiac reserve because their heart is used to this kind of change, and the body is demanding more oxygen and more blood. So they're kind of training their heart to be able to hold and change more effectively. So theirs go up to 600. However, if we have different types of diseases, and you don't need to know these diseases, except this one, which we will get to, but the point I'm trying to make here is that in these different diseases, we have a reduced cardiac reserve because the heart is not pumping effectively. The heart is not able to respond to different demands, or just overall, we're not seeing much of a change in the cardiac output from normal to exercise. And what we need to do to diagnose this is something called an exercise test, because what do we see? When do we see the cardiac reserve? We see it from a normal state to an exercise state. So we do this test when we see shortness of breath, muscle fatigue, or excessive heart rate. The important point here is that you need to know that the cardiac reserve is the percentage that the cardiac output can increase above normal. Meanwhile, the cardiac reserve will decrease for patients with different kinds of heart diseases. Does this make sense? Cardiac output is equal to venous return. Yes, Riham, that is correct. Okay, so with that, we have the end of the first part of the session. Here I have a question. What is the approximate rate of blood flow through skeletal muscles at rest compared to during exercise? Okay, awesome, some answers. Okay, yes, easy question. So it's B, 3 to 4 milliliters at rest and 200 milliliters during exercise, and we said this is a 25 to 50% or 25 time increase in the blood flow. Now, do you guys have any questions before we move on to the next part? Awesome, awesome. Okay, so now we're going to go into the cardiac circulation. The previous one was the skeletal muscle. Now we'll go into the heart specifically. You're on the CVP block. So we talk about coronary circulation. We're talking about the blood vessels that are supplying the heart itself. And when we have a disease in these blood vessels, affecting or supplying the heart, we're going to have a change in the entire body because the heart is what is supplying blood to the rest of the body. So if the heart itself is not getting blood, then the whole body is not going to get blood. And this is where we have something called coronary artery disease. This is a heart disease which involves the reduction in the blood flow. Sorry. So this is a heart disease which involves the reduction in the blood flow because of a buildup of atherosclerotic plaque. Now, what this means, I'll get to it in a second, but essentially is we have the coronary arteries supplying the heart. And in these cases, the coronary arteries will start having a buildup of substances. And because of this buildup, we're going to have a reduction in the blood flow, and a reduction in the blood flow will cause decreased blood reaching the heart, decreased oxygen, and decreased clearance of waste. And all of this will cause failure of the heart. We're going to get into more specifics of this in a minute, but this is just the overview of what it means. Now, some statistics on the top left corner that your doctor included was that there was 1/3 of deaths are due to coronary artery disease, and 45% of these are cardiovascular. Now, the important part here are the risk factors. We have 3 different categories of risk factors here. We have not reversible, or the non-modifiable risk factors, reversible, and partially reversible. We talk about not reversible risk factors. We have things that the patient cannot change about themselves, yet these factors are actively, pushing him closer to the disease. One of these is aging, so old age. Typically, it's above 40 to 50 years old. These patients are higher susceptibility to coronary artery disease. We have the male sex, so males are more likely to develop CAD than females. And we have genetic predisposition, any diseases that are affecting the patient genetically, which they cannot modify at all. These can also actively contribute to the disease progression. So these are the non-reversible factors. In reversible factors, we have things that the patient can change about themselves, like cigarette smoking, they can just stop smoking, hypertension, they can take anti-hypertension drugs, obesity, they can lose weight, and something called left ventricular hypertrophy is when the muscles of the left ventricle will expand due to different factors. This is kind of debatable. It could be partially reversible, but essentially this could be something that the patient could work on with drugs or different kinds of, lifestyle modifications, which will, reverse the hypertrophy. Then we have partially reversible. This depends on the patient's condition. Again, a lot of these factors will depend on the non-reversible factors. For example, genetics can contribute to the cholesterol triglyceride levels, which directly contribute to the atherosclerosis, which I will get to in a second. You can have hyperglycemia or diabetes mellitus. This is, kind of controllable, but, in some cases, the patient could not reverse these types of complications. And finally, we have low levels of HDL. As you guys might know, HDL is the good lipid. Meanwhile, high levels of LDL will predispose the patients to CAD. So this part is kind of important. I remember for our batch or some exam we had, it was an SAQ, and they asked us to write the non-reversible factors. Like they gave us an entire case and they were like, point out the non-reversible factors, point out the reversible factors. So familiarize yourself with these points and be able to answer them if you need to. Okay, so before we get into the disease itself, we want to talk about the plastic changes in coronary blood flow. What happens here, it's a very simple concept, is that when we have the heart itself and we have the coronary arteries supplying the heart, this happens by the coronary arteries kind of, going in between the muscle fibers, being able to supply all levels of the heart and all the muscle fibers. So what happens when the heart is constantly contracting? It's constantly pushing and constricting these blood vessels. So when the heart is in systole, which is the contraction, this systole will kind of, imagine this is the coronary artery. If it is within these muscles, if there's contraction, it's going to constrict the blood vessel. And because of this, the blood flow during systole is decreased. However, when we have diastole, it will release the pressure on the coronary arteries, and this will increase the blood flow and allow the flow to, continue. This is not something that's dangerous. It's normal for everyone, and it's just a split second because your heart is always beating. But just understand this concept as well. So just in word format, there is reduced coronary capillary blood flow during systole and increased coronary capillary blood flow during diastole. Okay? Understood? Okay, so when we go for the next part is the energy supply for the heart. An important point here is the fat metabolism, and I've put a star here to signify that it is very important. The star, you see it throughout the presentation, just know that this is a very important point, okay? So the fat metabolism is the main source of energy for the heart. Meanwhile, we have other points like glycolysis, which is seen more in skeletal muscle, but this can also apply for the heart, but to a lesser degree. And as we said earlier, the ATP is going to change into ADP, into AMP, and adenosine. And adenosine is one of the vasodilators of the heart. And this will increase the blood flow in the heart and allow for longer exercise. The problem with this here is that the adenosine is made at a very slow rate. You know, the heart is using ATP, but this conversion from ATP to adenosine is at a slow rate of 2% per hour. So what does this mean? If somebody has been exercising for the past 5 hours, and they are already predisposed to some sort of heart disease. Because of the slow rate of replenish adenosine, the heart is not able to continue contracting because the energy or the vasodilation is not enough. It's not being produced fast enough. So here, intense long-term exercise depletes energy stores of the heart, and the cardiac muscle cannot withstand a cut-off blood supply for 30 minutes or more. And this is especially important in patients who already okay. Now, this is basically the overview of what is important for the cardiac circulation. So let's get into the problems here. So when we have the coronary blood flow, we have different factors that can change the blood flow depending on how much it needs, okay? What this means is that when we have the heart and it is using up the oxygen, it's going to send signals to bring more blood flow. And with this, we bring our first point of something that controls the coronary blood flow, which is the myocardial oxygen consumption. If the myocardium or the heart muscles are using up more oxygen and the oxygen stores are actively depleting, this is the number one factor which will increase the coronary blood flow or will send out signals to increase blood flow, okay? Meanwhile, after that, we have our secondary and tertiary factors, which is the adenosine, like we said earlier, the flow down to adenosine will increase vasodilation. We have our nervous stimuli, the sympathetic and parasympathetic system, and we have other types of vasodilators. All of these will cause vasodilation and increase blood flow. But the most important point here is that the number one factor increasing the coronary blood flow is the muscle oxygen consumption. Remember this, there's a star here, very important. Okay? Now, what is ischemia? This is a lack of blood flow causing a shortage of oxygen and nutrients. Altogether, if we have different factors causing ischemia, these will all basically decrease the blood going through the arteries, and this will decrease the amount of blood and oxygen reaching the target muscles or the target organs that need this oxygen. And because of this cutoff, we might have a necrosis or a dying of these cells, because the blood flow and the oxygen is not enough. And we're going back on our points before, which is the atherosclerosis over here. What we have here is a buildup of fat, cholesterol, and other substances. And especially we have a buildup of LDL, which is the bad cholesterol, and a decrease in the HDL. And all of these factors together will build up something called an atherosclerotic plaque over here, which decreases the amount of blood that's being able to flow through these arteries. Okay, this is one factor of ischemia. Another one is a thrombus. A thrombus is a blood clot formed inside the blood vessels, and this will obstruct the flow of blood in addition to atherosclerosis. So this can happen either with or without atherosclerosis. But in this picture over here, we have our plaque over here, and we have this clot over here. This is made of different types of substances in the body, like fibrin, platelets, or red blood cells. All of this will form kind of a ball of waste products or blood or anything that's in the body. And this thrombus will move throughout the body until it gets stuck at a narrow point, like this one over here. This will completely cut off the blood supply and lead to ischemia. The third factor is a coronary artery spasm. As the name suggests, in the coronary arteries, there will be a sudden, twitch or contraction in the artery. and this sudden contraction will cause a temporary narrowing, which will also cut off the blood supply and lead to ischemia. Okay, so we have this over here just to give you the idea of the random spasm. And I've also included a schematic in the next slide just to reinforce these ideas. So once again, we have atherosclerosis. There's the buildup of the fats and the cholesterol, all of these causing a narrowing in the blood vessel. We have a spasm, which is just a random contraction in the blood vessels. This will also decrease the blood flow. We have something called a coronary dissection. This is basically the innermost layer of the artery will separate from the outermost layer, and this will cause a buildup of fluids and other things in this space where the separation was. And this will cause, again, a narrowing of the artery and decreased blood flow, okay? The final thing is oxygen supply demand alone, meaning that the demand of the heart is higher than the supply of blood, and this causes an imbalance. And because of this, we have decreased blood flow in comparison to the demand. And all of this contributes to coronary artery disease and ischemia of the heart. You can see here this blue area of the heart here. Blue means there's not enough oxygen, and in this muscles, they are actively dying because they're not receiving enough oxygen. Okay? Any questions before we move on? I didn't get the dissection, no problem. So this is not a huge high yield point, but just so you can understand. We have our artery over here, okay? Like every other organ in the body, sorry, let me do this again. Like every other organ in the body, we have layers, right? We have endo, we have peri, we have, different layers of the body. So same thing in the arteries. We have the outermost layer over here and down here, and we have the innermost layer, okay? The blood will flow in these spaces over here. During dissection, what happens is that the innermost layer will separate from the outermost layer, like this, okay? This is a separation from the outermost to the innermost layer. These separations, there can be a buildup of different fluids, of proteins, of whatever it is to get in this place. Because of this separation and buildup, we have a narrowing of this space over here, where the blood is actually flowing. And because of this narrowing, we will have decreased blood flow to the heart. So it's basically just a separation of those layers of the artery, and that will cause a constriction in the lumen of the artery. Does that make sense? Thank you, you're welcome. Okay, any other questions before we move on? Okay, so you have this constriction in the heart. If this continued, or if there was no protective mechanisms, anyone who has ever had a spasm or anyone who's ever had just the slightest bit of atherosclerosis would die immediately. And that's not how the body works. So we have a natural protective mechanism in the heart called angiogenesis. What does this mean? We have two parts of this word, angio and genesis. Angio is blood vessels, and genesis is new creation or something that's coming about from nothing. So for angiogenesis, what happens? We have our blockage of the arteries, like we said before. Let's say we have over here on this side, okay? Actually, let's go back to this slide and explain it here. So if we have our blockage of the vessels, say at this point over here, what the body or what the vessels will do is that they will try to create new blood vessels so that the blood flow can bypass the blockage and go into these new vessels and reach the places it needs to reach. How does this happen? When a muscle is not receiving enough oxygen, it will release certain chemicals. There's one called VEGF. You don't need to know it, but just to put stuff in perspective. This chemical is going to be released, and this will work on the blood vessels and stimulate them to proliferate, and these new blood vessels will be able to supply blood to the places that were originally blocked, okay? This process is called angiogenesis, and this creates things called collateral circulation. Collateral meaning, another area. So we have new circulation in these areas which were previously blocked. And this is how the body can kind of compensate for an acute or sudden blockage in the arteries. However, the problem with this, even though it happens almost seconds after a blockage, it can only really develop in 2 to 3 days after an occlusion. beyond these 2 to 3 days, it reaches its maximum proliferation. At this point, there's no more arteries to proliferate. There's no more things to work from. There's no more space, really. And if this protective mechanism fails, the patient will die, essentially, because there's no more means to be able to create this new blood vessel proliferation. So yes, this will help for a short amount of time, and it is effective in this short amount of time. However, the patient needs to be treated immediately after this. They need to go to the hospital, get whatever treatment they're getting, so that this grace period that is offered by the angiogenesis is not used in vain. Because after these 2 to 3 days, it won't work anymore, and the patient may suffer from more complications. Okay, just a schematic that your doctor included. It has the same sort of concept. So in a normal patient, let's say we have these vessels that he included. And in this one that I'm drawing right now, we can see that this collateral, or this vein over here, is closed. There's no blood flowing through here. However, if we get, let's say, a clot over here, completely blocking off this area over here, we're going to have the blood flowing through here and barely any blood flowing in this area over here. What this does is that the more blood over here will cause a pressure in these areas, and this pressure will also start pushing on this closed artery over here. This will start to open, and this creates our first collateral. Now, this is different from angiogenesis. This is just an opening of a collateral that was previously closed. If we're talking about angiogenesis, we're talking about the release of these chemicals, again, like we said, VEGF. This will work on the arteries themselves, and this will start branching out and creating new blood vessels. And this is what we call angiogenesis. The opening of a previously closed artery is a collateral. Does this make sense? Before we move on to the next part. Yes, okay. Any questions? You guys can ask in the chat or on mute. So after we have this sorry, there is a question, but it was always there. In some cases, collaterals, yes, they are there. They're just closed. They're not being used because the body doesn't need that much blood flow. However, for angiogenesis, this is the production of new blood vessels. These ones were not there before, and they are made new in response to a blockage or decreased oxygen supply. Again, meanwhile, the collaterals are usually there, but they're closed, not in use. Does that make sense? You're welcome. Okay. So we have our blockage, we have our decreased blood supply, we have all this. Now what happens after that? If these, let's say, these problems are not being resolved effectively, we can have different means of death in these patients. The first one I want to point out is decreased cardiac output. And this makes sense because we have a decrease in the contractility of the heart, right? So if we have this blockage, we have decreased blood flow, we have decreased oxygen, and we have decreased clearance of waste. All of this together will decrease the contractility of the heart and the effectiveness of the heart. So because of this, we have our first complication, which is decreased cardiac output. Less oxygen supplied to the cardiac muscle decreases the efficacy of the heart, okay? Another complication is pulmonary edema. When we talk about pulmonary edema, I want to look at this one over here. We have the circulation in the heart. We know that it starts from the right atrium to the right ventricle to the lungs and back to the left atrium to the left ventricle. What happens here is if we have the left ventricle failing, say that we have a cutoff in the artery supplying the left ventricle, the blood will fill up in the left ventricle. And because of this, the blood will also fill up in the left atrium because it's backing up. It's not getting rid of this blood effectively to the rest of the body. The blood backing up in the right atrium, where is it going to go? It's also going to back up in the lungs, in the pulmonary arteries and veins. This causes the pulmonary arteries and veins to increase their pressure, and an increase in pressure beyond 28 millimeters mercury is a very dangerous point because at this point, the amount of blood in the pulmonary vessels is so much that the blood will start leaking out of the blood vessels because it can't withstand all of this pressure. And this leaking out will cause the blood to start to pool in the lungs, and this causes congestion and something called pulmonary edema. And As you might know, edema is the collection of fluid in the extravascular spaces, meaning outside the blood vessels. So all this fluid will start building up in the lungs, and the lungs cannot effectively, exchange gas. It cannot, continue the blood flow. And because of this, the patient will die by something called suffocation within 20 to 30 minutes following acute heart failure. So this is why immediate resuscitation and immediate treatment is very critical in these patients, because they can die by pulmonary edema, which is literally your lungs and your heart suffocating itself because of this liquid buildup. Okay, so that's pulmonary edema. The blood will pool in the left ventricle, and this will back up in the left atrium, which will back up in the lungs. This will increase the blood in the lungs, in all the vessels in the lungs, which causes the blood or the fluid to leak out of the vessels into the lungs, causing congestion, causing pulmonary edema, and eventually suffocation, which causes death. Okay? The third one is fibrillation. We have our normal contraction of the heart, which is at a rhythmic pace. However, when we have fibrillation, this is due to an interruption in the blood flow or the nerve stimulation. And the heart muscles will contract randomly and rapidly and ineffectively. This is ineffective because we need our contractions to be rhythmic and strong and at a certain pace. When we have this random fluttering or random, let's say, contraction, this causes the heart to fail in actually pushing out the blood. And this is another way that we have, death of the patient. You guys might have studied atrial fibrillation, ventricular fibrillation, all of that stuff. These can all be consequences of coronary artery disease, okay? Another one is a rupture of the heart. So we can literally just have the heart muscles burst and break. This is because, again, the decrease in blood will increase the weakness of the heart muscle, and because of the increased pressure by the backup of blood, this will cause a rupture of the heart muscle. Okay, and we can see it here in this diagram. This area over here has had a complete rupture, and we can kind of see some areas of black here, which is the necrosis or the cut-off blood supply. The last one is cardiac tamponade. Should be written here, tamponade. So what this is kind of similar to this dissection, but what happens here is that the layers of the heart will again separate. And in the separation, this follows the rupture of the heart. Because if we have, say, the layers of the heart here, and then we have kind of a break over here, the connection here and here and here and here will be cut off. So these layers will start to separate like this, and blood will start flowing in between these layers. And we can see that over here, all of this here is a collection of this blood. What this does is that it presses on the muscles and it presses on this empty space here where the blood is supposed to sit. And this will also decrease the amount of blood that the heart can hold, hence decreasing the amount of blood reaching the rest of the body and decreasing the contractility. So these are 5 of the main causes of death. Again, decreased cardiac output because of the decreased blood and decreased oxygen. Pulmonary edema because of the backup of the blood from the left ventricles to the left atrium to the lungs. Fibrillation because of the cutoff of blood supply and nerves. Rupture of the heart because the blood supply is being cut off. We have weakness in the muscles, which causes a rupture. And cardiac tamponade, which is the separation of the layers of the muscle and the accumulation of fluid. Okay, let's see some questions. What would cause the blood to pool in the left ventricle? Okay, so in the left ventricle, like we said, if we have a coronary artery which has a thrombus or atherosclerosis, what happens is that the blood reaching the left ventricle is decreased. If we have decreased blood, we have decreased oxygen, we have decreased ATP, we have decreased everything reaching the left ventricle. So what happens is that the left ventricle is not able to contract effectively. If it's not able to contract, the blood is not being pushed out of the left ventricle enough. Because in a normal situation, the left ventricle should be able to contract fully, expelling all the blood from the left ventricle into the systemic circulation. But if we have decreased contraction, some of the blood will get out, but some of it will stay. And then the blood will come from the left atrium, and then again, it'll contract a little bit, but not all of it will leave. And then again, the left atrium will bring more blood. So this blood is going to build up, and as it builds up, it's going to start backing up in the left ventricle, and then it's going to start building up in the left atrium, and then this backup will also extend to the pulmonary circulation. Does that make sense? Can you explain the tamponade again? Yes. So again, it's kind of the same situation as the aortic dissection. Like we said, let's look at the rupture of the heart here. We said that there can be a rupture in the heart, yes? We have these two layers. We have the innermost layer of the heart here and the outermost layer here. These are two distinct layers of the heart. What happens is after a rupture, these parts should be connected here. This part here and this part here should be connected. But because of this rupture, we can have a separation of the innermost layer and the outermost layer. When this happens, you can see in this photo here, when this happens, in an ideal patient, we should have something like this on the left. If you look here, we can see the outermost layer and the innermost layer. In this patient, we have the innermost layer down here, we have the outermost layer over here, and we have a collection of fluid over here. And how did this happen? It's because we had a rupture which separated these two layers, and the blood and different fluids and everything was able to get in between these two layers. And because of this collection of fluid, it presses on the muscles of the heart, it presses on the heart itself, and it kind of prevents the heart from dilating effectively. And if it's unable to dilate effectively, it's not able to hold as much blood, and it's not able to contract properly because there's this fluid and pressure that's pushing on it, and it's not able to contract properly. So what a cardiac tamponade is, the tamponade itself is the fluid building up in between the two layers of the heart. Normally, there should be no fluid in these areas except for, the lubricant fluid to allow the smooth contraction, but this fluid is pathological. It's not normal. This is because the layer separated and more fluid came in between these spaces, which actively compresses on the heart and decreases contractility. Does that answer your question? Yes, thank you. Isn't cardiac tamponade a buildup of fluid in the pericardial cavity between the visceral and parietal pericardium? Yes, that's basically what I said. It's the buildup of fluid in between these two areas. I think we might have gotten messed up. Like I said, the two layers will separate, like you said, the visceral and parietal pericardium. So this is basically these two layers over here. Here, visceral and parietal. These two layers will separate, and there's going to be a buildup of fluid in this area. So yes, you're right. It's the same thing. All good? Awesome. You're welcome. No problem. Okay. Now, we're getting to the end of this part, hopefully. What we have here is just a kind of schematic diagram to the actual ischemia in the heart. I don't think this is such an important graph. Your doctor just included it, so I'll just go over it quickly. But what we have here is, in this outer layer here, this is the mild ischemia. This is cardiac cells which are being actively cut off in blood supply, but they're still functioning. They're getting to a point where they might reach complete cutoff and in complete non-function, but at this point, they're still working. This area over here, Taban, it's not actually white and purple and red. This is just the drawing itself, which is why I don't think this is this important, but just understand the concept. When we have the ischemia, the outermost circle is mild. When we go inwards more, we have non-functional cells. These ones have been cut off from the blood supply. They're not working, but they're still alive. Okay, this purple area means that they're still alive. They're non-functioning. Then if we look down here, we have this red area here, which is completely dead fibers. They have been completely cut off. They're not functioning and they're completely dead. These fibers can form a scar or fibrous tissue, which is this white one. And what happens with scars? They kind of shrink in size and contract to the areas around it. So when we have this scar, it's kind of pulling on the rest of the muscle around it and kind of increasing this dysfunction of the heart. Okay, so what you kind of basically need to know here is just the flow of the ischemia. So we start number one with the mild ischemia, meaning the cells are still functional, but they are functional at a decreased capacity. Then we have the non-functional cells. They're still alive, but they're not working at all. This moves on to the dead fibers. These are dead and they're not working. And these dead fibers will move on to the fibrous tissue, which are not working, and it's scarring and it's actively contracting or kind of traction pulling on the rest of the heart. Okay? This is what I want you guys to know from this photo. Not that important, but Just know it for the sake of your exam. Okay? Now we've talked about the pathophysiology, we've talked about the physiology and everything behind the ischemic heart disease and coronary artery disease, but when we want to talk about the actual presentation in the patient, we have something called angina pectoris. This is a pain felt in the upper sternum. So angina means pain, and pectoris, the pec muscles or the pec muscles. So it's felt in that area. It's pain in the upper sternum. The sternum is the muscle in the center of the chest here, holding all the ribs. And this pain is being referred, or as you guys know, referred means pain felt in another area, to the left arm and the left shoulder. You guys might have heard this presentation in a lot of other places. It's a very common and well-known presentation. So if you suspect coronary artery disease, you're suspecting pain in the upper sternum, referred to the left arm and left shoulder. Okay? For the treatment, we have a bunch of drugs. Your doctor said that you don't need to know these drugs, but just for the sake of completion, just know the basic idea. We have vasodilators to help with the flow of blood. We have alpha receptor blockers and beta blockers. These are the receptors that the parasympathetic and sympathetic system will work on. We also have something called calcium channel blockers. If you're blocking calcium, there'll be decreased contractility. And we have different types of surgeries. The surgeries are kind of more important to know than the drugs themselves. So over here we have CABG and we have angioplasty. For the CABG or the coronary artery bypass grafting is we basically connect a tube from the subclavian artery down to the muscles of the arm or the muscles of the heart. And this will increase blood flow to these areas which were previously blocked. So we're kind of creating an artificial artery or coronary artery. In angioplasty, we're inserting a balloon into the previously constricted blood vessels, and this balloon will start to dilate, and this dilation will open up this vessel again to allow increased blood flow. So again, just know these two different surgeries. They're very simple to know. And inshallah, that should be all the doctor requires from this part. So again, know the angina pectoris. This is a very important and significant clinical presentation. Pain felt in the upper sternum radiating to the left arm and shoulder. Know the basic idea of the treatment. We need a vasodilator and the sympathetic and parasympathetic blockers, alpha receptor blocker and beta blockers, calcium channel blockers, all those. And know the two surgeries, which is the CABG and the angioplasty or the angio balloon. Okay, let's end this part off with a question. In the event of acute coronary occlusion, new blood vessels may form as an alternative pathway to the blocked vessel. This process, which creates anastomosis, is called, you guys can answer. Good job. Yes, C. Like we said, our angiogenesis is the creation of new blood vessels, and this will create a bypass for the rest of the blood to pass. Okay, any questions before I move on to the last section? Okay, the last section is about 20 more slides. Do you guys want a break or should we just finish it? Let's go. Let's go. Okay. So the last part of this lecture is cardiac failure. This is kind of the end stage of everything that we've talked by now. And what we're going to do in this part is we're going to have a lot more graphs that we're going to get into in a second. So let's look at this. Cardiac failure is defined as the inability of the heart to pump enough blood to accommodate the needs of the body. So everything we said before is kind of a reduction in the cardiac output, but this is when the heart completely fails, meaning the body is asking for more blood and more oxygen, but the heart is just not able to keep up with this demand. And this could be because of the things we mentioned before, which is the diminished coronary blood flow, because of atherosclerosis, because of a spasm, because of a lot of different things. It can be because of damaged heart valves. So if we have the heart valves are kind of closing off, then this will decrease the outflow of blood, and hence we're going to have cardiac failure. We can also have vitamin B deficiency. It's very disease. This is more significant in your mole lectures. So this is when the myocardial or the heart muscles are starting to fail because of vitamin B1 deficiency, and this will create cardiac failure. And another one, like we mentioned, the cardiac tamponade, which was the accumulation of the fluid between the layers of the heart. And we have primary diseases of the myocardium, meaning diseases that are just originating from the myocardium without any other causes. Okay, so just the basic idea here is that the body is asking for more and the heart is not able to supply. Now, here's our next important graph here. My pen died, so I'm going to be using my mouse. So excuse me if the illustrations are not good. But essentially here, we're going to start with point A, okay? What I want you guys to focus on here is, again, the right atrial pressure and the cardiac output. What happens here is at point A, we have the right atrial pressure at 0 and the cardiac output at 5. Okay, this is in a normal situation. We want the right atrial pressure to be 0. We want the cardiac output to be 5. Okay, what we're going to go through is step by step what happens in cardiac failure and how this changes the graph and how this changes different parts of the graph as well. So let's take a look. First, we're going to talk about the acute effects, everything happening immediately after cardiac failure. So immediately after, what happens is that we have a reduced effectiveness of the heart. We can see this in a decreased cardiac output and a high atrial pressure. This is very important. 2 stars here. Remember these points. And we'll see it directly on the graph. Like we said, point A is normal. In acute cardiac failure, we move down to point B over here. What can we see here? The right atrial pressure has increased to +4, and the cardiac output has decreased to, let's say, this is around 2. So the 2 main points in acute cardiac failure is decreased cardiac output from 5 to 2 and increased atrial pressure from 0 to +4. Okay. 2 other things that you need to know here is the damming or accumulation of blood in the veins, because if the blood is not pushing out or if the heart is not pushing out blood, then this blood will pool in the heart and then more blood cannot come into the heart because the heart is already full. So the venous pressure, like the superior vena cava, the inferior vena cava, they're going to have an accumulation of blood, which will increase the venous pressure. This increase in the venous pressure will, again, a lot of this stuff is just, backflow, backup, all of this stuff. So if we have a backup in the venous pressure, it's going to continue to back up in all of the systemic circulation, and it will have kind of the same effect as the pulmonary edema, where we had the blood vessel over here with the accumulation of blood, and too much of this will start to leak out, and the buildup of fluid or blood in the extracellular spaces is edema, so we have edema as a result. However, one point I want to make is that edema is not an immediate complication of cardiac failure because we have compensatory mechanisms, and I'm going to get to this in a bit, but just what you should know is that edema will not happen immediately at this point. It will happen eventually, so keep it in mind, but not right now. Okay? So, like we said, we reached point B. What happens after point B? Okay, this is the decompensation. The heart will immediately kick in. The kind of physiological changes of the heart and the body will immediately come in and try to fix this. And this is when we activate the sympathetic system. Okay, what happens here is we move from point B to point C. This is the activation of the sympathetic system. What happens here is that the cardiac failure will cause the decrease in the right atrial pressure and the decrease in cardiac output. This will trigger a lot of reflexes in the body, like something called the baroreceptors, the chemoreceptors, central nerve system, and the reflexes in the damaged myocardium. Don't need to know this in much detail, just know that after we have the acutely damaged heart, it will start triggering reflexes, and these reflexes will start kicking in the sympathetic system. This will cause vasoconstriction, increased contractility, increased heart rate, all of these things. And all of these will bring it to point C, which is the sympathetic activity at its maximum point. And as you can see, this has increased the cardiac output from what we said was 2 originally here to, let's say, 4. It's not exactly what we needed, which was 5, but it's getting there, okay? So we started at point A, which was the normal heart. We had cardiac failure, which brought it down to point B. And then the heart and the body immediately started kicking in. The sympathetic system started working, and it starts bringing the cardiac function back to its place. Okay? Don't baroreceptors inhibit sympathetic? To a certain degree, I know what you're talking about, the one where people massage their, you know, what's it called, the neck to relax the heart rate. However, part of the baroreceptors do have some sympathetic effect. And this is because when the heart is working and pumping through the arteries that are going up to the brain, this pressure also works on the baroreceptors, and part of it will stimulate the sympathetic response. Again, this is something that your doctor has written in the slides. I do agree with you to a certain extent, but because this is what he wrote, and it was the very first point he wrote on the slide, I want you guys to take this with a grain of salt, that the baroreceptors will have some sort of role in the sympathetic activity, okay? Now, like we said, we started from point A, which was the acutely damaged heart, which goes down to point B, which is the damage, and then this activates the sympathetic activity. All of this sympathetic stimulation will make the heart a stronger pump. What happens after this? We move from acute to chronic. Now, the sympathetic was the first step, but that's not enough to bring the heart back to its working state. So we have another kind of reflex that works, which is the kidneys and the hormones from the kidneys and everywhere else. What this does is that the kidneys will have a huge effect on the blood pressure. You guys might know that the heart and the kidneys both work together to control or regulate the blood pressure. The kidneys will sense this decrease in blood pressure because the heart is not pumping enough blood out, so there will be decreased blood pressure, and it will act accordingly. This is by a lot of different mechanisms, which I don't think you have to know because it's very complicated and it will be explained in your renal block. But essentially, we have an increase in renin, in angiotensin, and aldosterone. These three are kind of chemical mediators which will increase the blood pressure. We'll also have water retention because of the aldosterone. Aldosterone is a kind of substance which will increase the uptake of water or decrease the excretion of water. And all of this stuff will keep more fluid in the blood vessels so that we can increase the blood pressure. Another thing is that the body will decrease the urine output, so we're losing less water, so that more fluids stay in the body and it will increase the blood pressure. Okay, so for point D, what we're doing is we're having the kidneys kick in and start to regulate the blood pressure. Okay, this will increase the blood volume and this will increase us from point C to point D. Now, two important points here. Because of this increase in blood volume, the atrial pressure will increase. We can see here, it moved from here to about 6 over here. Why is this? It's because we have more fluid in the body. More fluid in the body means that more fluid is going back to the heart. More fluid going back to the heart means that the atrial pressure will increase. However, this is something that we're willing to sacrifice for the cardiac output. When we talk about point D, this is compensated heart failure. Why is it compensated? Because we have reached our desired cardiac output. As you can see here, cardiac output at point D is the exact same as point A. So this entire process, starting from the cardiac failure, the sympathetic stimulation, and the kidneys and everything in between that, was done for the purpose of going back to our baseline cardiac output, which was 5 liters per minute. Yes, this is at the expense of an increased right atrial pressure, but this is what the heart has to do to maintain a cardiac output which keeps the patient alive, okay? So if our cardiac output goes down and goes back up to 5 liters per minute, back to its normal baseline, this is compensated. This is dealt with. This is back to kind of a baseline, although this patient is at risk for certain diseases if they go into exercise or if they're putting strain on their heart, again, because the right atrial pressure is very high in this state. This patient needs to go get treated properly, but this is kind of the way the body protects itself, okay? Any questions before I move on about this graph? Awesome, awesome, okay. So just a quick pivot over here is that how does the body know what to do when the right atrial pressure increases? It knows this by something called an atrial natriuretic peptide, or ANP. This is a peptide which is released from the atrium when the pressure increases. It is a natural protector in heart failure. So we have, like we said in this graph, in the previous graph, we have the right atrial pressure increasing, right? When this happens, the right atrium, again here, we have +6 pressure. When it increases, the right atrium will start to release ANP. ANP will go and act on different parts of the body, like the kidneys, the heart itself, the vascular system, and the nervous system. And all of these will work together to kind of compensate for this heart failure. This is just something you need to know if they ask in the exam the role of ANP, or they ask how is the body knowing when to respond to heart failure. Just know that it is because of the stretch of the wall in the right atrium, and the stretch will cause the release of ANP, and this ANP will go work on the rest of the body. Okay? Now, yes, this will compensate for cardiac failure for a while, but it's kind of a double-edged sword, and I put it over here just to visual memory. But essentially here, when we have this increase in fluids, this is putting the heart at kind of a risk. Yes, it is helping maintain the blood pressure, and yes, it is helping maintain the blood flow, but it's also putting the heart at risk because the heart is already working as hard as it can in its damaged state. So if we're adding more pressure and more fluid onto the heart, this can further exacerbate the already weak heart itself. So we have our fluid retention here. More fluid going to the heart will increase the workload and damage it further. This will overstretch the cardiac muscle because the atrial pressure is increasing. We'll have, again, our symptoms of pulmonary edema. We'll have peripheral edema in late stage. And all of this, if we let the cardiac failure continue for a long time, these are the complications that can happen. So again, everything related to cardiac ischemia, cardiac failure needs to be treated immediately. It needs something to, get to on the spot, because the complications, even if they're helpful in the moment, they can, get worse later on. Just this point over here, how we have recovery of the myocardium and the myocardial infarction. We have, again, the collateral blood supply, which was the angiogenesis, and these will come into the myocardium and allow more blood supply. And another important point over here is hypertrophy. So if we have this part of the heart is not working, this blue part over here. Meanwhile, the pink parts are working. Because this blue part is not working anymore, the pink part has to work twice as hard to compensate for the blue part that isn't working anymore. And because of this, since they're working twice as hard, the muscles are working more and more and more. And when you overwork a muscle, we have something called hypertrophy. And hypertrophy is the expansion of the muscles. They get bigger, they get stiffer, they, expand in shape and size. And you can kind of see it here. The heart is kind of bigger here. I actually can't tell if it's bigger, but essentially it should be bigger. And this hypertrophy will try to compensate for the dead muscles. And alongside this hypertrophy, again, we have angiogenesis, and these two will try to recover, but they are not long-term solutions. The patient does need to go get proper treatment at the hospital, okay? Okay, so again, this is kind of just a reiteration of what I just said. For compensated heart failure, we've moved from point A to point D. The cardiac output is back to its normal state, but the right atrial pressure has increased by a lot. Because of this, you can see a difference over here as well. This is our cardiac, the maximal cardiac output that the heart can achieve. So if this normal person over here were to exercise, their cardiac output can increase all the way up to here. However, if the person at point D is exercising, there's literally no room of increase. This is the only cardiac output they can achieve, as compared to this patient who can have all this cardiac reserve to increase during exercise. So if this patient at point D starts exercising or overworking themselves, they can go into a severe state of hypoxia, which is decreased oxygen. They can go to further worsen their heart failure, all of this stuff, because the cardiac reserve is reduced. So this is an important point. It should be 3 stars here. If we have heart failure in a patient, their cardiac reserve is reduced greatly, and they're not able to exercise or overwork themselves, okay? Okay, any questions so far? Okay. Great. So The next part is cardiogenic shock. This is just kind of emphasizing what we've already talked about. So when we have cardiogenic shock, again, this was a drawing that was in your doctor's presentation. I'm not a huge fan, but I'll explain it for the sake of the completion. So if we have reduced cardiac output, the blood here is decreased. You see, there's only drops. Meanwhile, it should be a complete stream of blood. We have reduced cardiac output. What happens is that the blood starts to pool up in the rest of the heart, okay? Assume this whole thing is the heart, this entire jug. So the blood starts to pool in, and this is increased preload, which is the blood that is entering the heart. This increased preload will cause increased pressure in the heart, and the heart is already struggling to get out blood. So if there's more blood coming in, it's not going to be able to, get this blood moving along. It's just going to put more pressure on the heart. So if we have increased preloads, that further exacerbates the cardio malfunction. Now, let's take a step back, just define shock. Shock is when there is decreased perfusion of blood or oxygen reaching the rest of the body. And this can be caused by a lot of things. This can be caused by hypovolemia, meaning low blood in the body. So the blood is not reaching these peripheral organs and they're not supplying blood or oxygen. This can happen by infection, which is septic shock. And in our case, this is cardiogenic shock, which the heart is not pumping enough blood to even reach the rest of the body. So if we have cardiogenic shock, the blood will start to pool in the rest of the heart here, and this further exacerbates the decreased output. Another point is the afterload. The afterload is the pressure that the heart is working against. So if we have, let's say, our stenosis, or we have vasoconstriction, we have atherosclerosis, we have anything that we mentioned before, this will increase the afterload, and the heart will keep trying to pump against this pressure. And regardless of how much it works, it's not going to be able to be as effective. So these are kind of what I think the doctor was trying to get at with these drawings. If you want to skip these drawings, honestly, go for it. I don't see this being used anywhere. So I just explained it for the sake of the doctor because he added it. What you do need to know is that a pressure in the coronary artery has to be above a certain point to be effective. If the pressure falls below 80 millimeters of mercury, then this can cause deterioration of the myocardium because reduced pressure means reduced blood flow in the heart. This is going to reduce the perfusion of blood from the arteries into the actual muscle, and this will cause decreased oxygen, decreased blood flow, all of that, and further exacerbate the myocardium. So if you want to take anything from the slide, take the number here, and this is kind of the threshold for the deterioration. Okay. As you can see, that is the only slide he included in cardiogenic shock, so take it with a grain of salt, but let's move on back to the heart failure. So we discussed the compensated heart failure, which was the cardiac output decreases and then goes back to its 5 liters per minute. So if it goes back to its original or baseline cardiac output, we consider it compensated. If the cardiac output is not able to reach its baseline once again, this is decompensated. We can see here at point A, we start to have our decompensation or our heart failure. We have our sympathetic stimulation going to point B. We have our renal kind of initiation going to point C, but this is not enough. It will not be able to restore the normal cardiac output, and we can see that it just completely falls short of our baseline over here. So the patient will continue to, start retaining more fluid in the kidneys, the urine output will decrease, the blood pressure will increase, and all of this will keep building up, and the heart is still not able to reach its baseline. And this buildup, without any proper effect, will continue to make the condition worse and worse. The patient will develop edema in the lungs, in the periphery, and this will lead to death. So the main cause of decompensated heart failure is the incapacity of the heart to pump sufficient blood to make the kidneys excrete daily the necessary amount of fluids. So again, it's just kind of a vicious cycle of the heart not being able to work, the kidneys trying to help, but it not being enough. The kidneys continue to keep more fluid in the body, and this will continue to exacerbate or make the condition worse. Okay? Does this make sense? Any questions? Okay, let's go to the edema part. So like I said earlier, what did I say? I said that we will not have edema in the acute stage of cardiac failure. This is because we have certain compensatory mechanisms. So if we have the heart working over here and we have the aorta, the aorta is part of the afterload per se. So if there's a lot of blood in this area, the heart will have to contract more. So what does the aorta do? It decreases its pressure so that more blood can flow in this, in a state where the heart is not contracting properly. So we start with a normal aortic pressure of 100 millimeters mercury, and as soon as heart failure starts, the aortic pressure will start to decrease so that the heart can allow the blood to move through the aorta. Another thing is that the right atrial pressure, like we saw in the previous graphs, starts from 0 and begins to increase and increase and increase. The capillary pressure itself, because of these two changes in the aorta and the right atrial pressure, the capillary changes are not that significant. And when we're talking about the edema, the capillary pressure is kind of what really matters in these cases, because these are the places where the edema will happen. It won't happen around the aorta or the right atrium. It's the capillaries in the rest of the body and in the lungs. So if we have these changes in the aorta and the right atrium, all converging to one point, which is 13 millimeters mercury, this kind of decreases the gradient. So say we have kind of a high pressure place going to low pressure, the blood will move to the low pressure, and in these low pressure areas, there will be blood buildup, and in these buildups, we'll have edema. The point I'm trying to make here is that when the aortic pressure and the right atrial pressure come down to or up to the same pressure as the capillaries, this gets rid of the gradient, and this kind of protects the body from edema until the heart can try to, lock in and get back to its work. However, in chronic conditions where this continues to get worse, these compensatory mechanisms are not enough, and the pressures will eventually go back to their original numbers, and the capillary pressure will start to increase and increase, and then we'll see the blood and the fluid leaving these capillaries and causing edema. This graph is a bit roundabout way of explaining the edema, but this is the way the doctor wants it explained. If you guys have any questions, feel free to ask, otherwise we'll continue. So hence, in severe acute cardiac failure, there's a fall in capillary pressure because of this compensation. This is in acute. However, in chronic, this fall in capillary pressure is not enough to compensate, and we will have the rise in edema. Okay, this is basically the same thing. The long-term fluid retention by the kidneys. Again, the kidneys are doing all these different things to increase the blood pressure, and there's more fluid. This will all cause the peripheral edema to happen more efficiently because the blood pressure in the capillaries are increasing. These are due to many mechanisms: glomerular filtration, renin-angiotensin, aldosterone, sympathetic system. Again, don't focus on the specific mechanisms. They're going to be discussed in your renal block. For now, just know that when we have long-term decompensated heart failure, the kidneys will continue to increase the fluids in the body. This increase in fluids causes more pressure on the heart, causes more pressure on the capillaries, and this will lead to exacerbation of the cardiac failure and eventually peripheral edema. Okay? Once again, keep in mind that peripheral edema, peripheral meaning in the further away areas of the body, like the hands and the legs, this happens later on. It does not happen in acute heart failure, okay? This is kind of a repetition of the pulmonary edema. Again, if you didn't get the first time, we have the left atrial pressure or the left atrial blood pooling in, or the left ventricle first, pooling in the left ventricle, then pooling back into the left atrium. This will move backwards into the pulmonary vessels. This will increase the blood in the pulmonary vessels, which will eventually leak into the lungs. And this leakage causes buildup of fluid, congestion, and suffocation. Different ways to bypass this or treat this is a tourniquet. A tourniquet is kind of a band or, let's say, a belt that people put around limbs to cut off the blood supply. If we put this on the arms or the legs, this will decrease the flow of blood through these vessels, and this will decrease the amount of fluid returning back to the heart and decreasing the workload on the heart. This seems kind of controversial because we are cutting off blood supply to these places, but this is usually very temporary to just, relieve the heart for a moment. Then we can have stuff called diuretics. These are drugs that are given to the patient, which will increase the excretion of fluid. It will increase urination. So this will kind of work against the fluid retention in the kidneys. So that's another way to bypass this. We give pure oxygen in cases of pulmonary edema because the patient is not able to take in this oxygen. And we can give a cardiotonic drug, which is basically just a drug that increases the contractility of the heart. Okay, any questions? This is going to be the last part of the lecture. If you guys have any questions, let me know. Okay, last part of the lecture, not really a part itself, it's more of a summary of what we've done. It's just putting all the graphs together and we can look at it all together in one final position. So if we again start from point A, this is our normal cardiac output, normal venous return. As you can see, the venous return graph has made a comeback. And what we're just looking at here is the flow of, sequence of events that's happening during cardiac failure. Okay, so again, we have our starting point A. The patient goes into cardiac failure to point B. The heart and the body starts to react, increasing sympathetic stimulation. So we reach point C. And then chronically, the kidneys and the hormones will start to kick in, increased fluid retention to point D. And we're back at our baseline point of 5 liters per minute at the expense of an increased atrial pressure. Okay? This graph just shows the decompensated heart failure, but in the perspective of the time. So in this point, we have, again, point A, normal venous return. The cardiac output is trying to increase back to its original of 5 liters per minute, but it just falls short. This green part over here tells us it's day 2. By day 6, we are way below the baseline cardiac output by 0.8. At this point, the patient is dead. You cannot thrive in these conditions with this low of a cardiac output. So this just puts the same thing in the perspective of a timeline. Not that important. If you want to memorize the days, you can, but focus more on the mechanism of compensated and decompensated heart failure in relation to these graphs, okay? Last slide, we have this thing that the doctor ended his presentation with. So this is high output cardiac failure. Everything we discussed before this was low output cardiac failure. Why? Because the cardiac output was very low. The heart and the body were trying to compensate for the low cardiac output. Meanwhile, in this case, we have something called high output cardiac failure where the heart is pumping out a lot of blood, like insane amount of bloods, yet this is not enough to meet the body's metabolic demands. Meaning the heart is pumping out, let's say 25 liters per minute, which is a lot, yet the muscles, the organs, everything in the body is still not receiving the required oxygen. Why is this? We have different cases. We have something called arteriovenous fistula. This is a fistula is a pathological connection between two structures. So if we have, this is the artery here, and we have, this is our vein. A fistula would be a connection between these two areas. This is different from the, what did we say, the collaterals forming, because the collaterals were already there and they're normal. A fistula should not be between an artery and a vein in the first place. In those cases, it was between two arteries to allow the blood to flow through, but a fistula between an artery and a vein is controversial because we're going to have a connection between oxygenated and deoxygenated blood, and this blood mixing is not a good sign. If we have the blood moving from the artery to the vein, because the artery is higher pressure, so it's going to move into the vein, we're going to have decreased peripheral resistance because all the blood moving here might move into the vein and less blood will continue down. And this is going to help the heart, yes, because the heart is able to push against less resistance, but this blood is not sufficient enough to supply, let's say, our muscles or our organs, okay? So this is kind of the idea of a high output cardiac failure. The heart is pumping a lot of blood, but this blood is not reaching its desired targets and it's not meeting the demands of the body. Another example is the beriberi disease that we mentioned earlier, vitamin B1. If we have a weak myocardium, as we know that in normal states, if we have heart failure, the heart will try to contract faster and more to compensate. But in a weak myocardium, the heart will not be able to pump more. This will cause decreased renal perfusion because the kidneys are kind of listening to what's happening to the heart and trying to act accordingly. If we have decreased renal perfusion, the fluid that the kidneys would normally hold on to will be released, and this will increase the mean systemic filling pressure. Okay, sorry, the decreased renal perfusion means that the blood entering the kidneys is less and there's more fluid retention. Sorry, I'm very sleepy today, but the fluid retention will increase and this increases the mean systemic filling pressure. Now, this is at the very end of his presentation, not that high yield in my opinion, but know how it looks on the graph. So the arteriovenous fistula, like we said, it has a very high cardiac output. However, this is not meeting the demands of the body, so we can see that there's a decrease over here as we move along the graph. In the beriberi heart disease here, we can see that the myocardium is weak because of the contractility. Even though we have this point C here, we have a very high atrial pressure. However, the cardiac output is pretty high as compared to the normal 5 liters. Okay, so just keep in mind, everything we've discussed before this, heart failure, ischemia, all of this before was low output cardiac failure because the cardiac output was decreased in these situations. In these two, arteriovenous fistula and beriberi disease, we have an increased cardiac output, yet it is not effective enough to reach the demands of the body. And with that, we have our last question. So what is the main cause of death in acute left ventricular failure? This is kind of a tricky one. Okay. Okay, good. Yes. Yes, it is C. The correct answer here is C. Because the buildup of fluids in the heart and the backflow of fluids back to the lungs is a very acute reaction, you know? If the blood is filling up in the hearts, then what's the next step that will happen? It's going to build up and it's going to go back to the lungs. That's the immediate reaction. So the main cause of death is due to the pulmonary edema and suffocation. Fibrillation might happen kind of at a later stage, and it's not always something that will happen in all patients. However, it is still significant enough to consider. I understand why you might have considered it, but pulmonary edema is known as one of the most common ones, okay? And with that, I conclude my session. Thank you all so much for tuning in and listening and participating. I know I went a little bit over time, but I hope this session was beneficial for you, and I hope that you all do well in your exams. If you need anything, you can contact me at any time, and I will help as much as I can. But other than that, that's it for me, and thank you all so much. If you have any questions, feel free to reach out or ask right now. Awesome. You're welcome. You're welcome. Alhamdulillah, I'm glad. Assalamu alaikum, everyone.